Hello, everyone. My name is Zach Grinspan. I'm a pediatric epilepsy doctor, and I run the pediatric epilepsy program at Weill Cornell Medicine, New York City. Amber, those were very kind words. You've made my day. Thank you so much. And so I'm here to talk about the trial that Amber's advocacy helped us do. So the name of my talk is phenylbutyrate for monogenetic DEE. We started it with SLC6A1 and STXBP1 based on the good effect in those populations and for the behind-the-scenes advocacy for Amber and others. We've been able to extend the trial. We initially enrolled 20, and now we have an enrollment of a total of 50. So they gave us enough drug for 30 more. These are my disclosures. And I did just want to start with a thank you. The way this was funded, as Amber said, is that we had the idea. We had two bench neuroscience labs, Katty Kang at Vanderbilt and Jackie Bure at our place at Cornell, who had both found that phenylbutyrate might work for these two diseases. We were able to convince the company, Horizon, now Amgen, to give us the drug, but it was funding from rare disease organizations, really fierce parent advocates that got us that initial seed money to get going. We now have funding from Amgen. They've given us not only drug, but some money to help us finish the trial. And then I also need to thank my teammates. We did this as a two-center study ourselves at Cornell and our colleagues at Children's Hospital of Colorado, and it's just been a real joy. It's been great. We've expanded our team quite a bit because of the funding, and the Children's Hospital of Colorado group is just amazing. For phenylbutyrate, this is an already FDA-approved drug for something else. It's approved for urea cycle disorders. It helps lower serum ammonia. It also happens to cross the blood-brain barrier. It comes in two flavors, as Amber said: sodium phenylbutyrate, which is the gross flavor. It's salty, it's bitter. I've heard lots of choice terms used to describe it, but it's really intolerable. Neurotypical people can tolerate it because they know it's going to make them feel better in the urea cycle disorders, but an impaired child cannot. There are taste-masked versions of the sodium phenylbutyrate that's out there. This is not CME, so Olpruva and Feburane are the brand names. The drug we use, though, is glycerol phenylbutyrate. That's Ravicti. And what it is, it's a glycerol backbone, and they kind of shove 3 phenylbutyrate molecules onto it. So when you drink the drug, those molecules pop off, and it works just like sodium phenylbutyrate. Several publications have pointed to this drug as potentially therapeutic for developmental and epileptic encephalopathy. Jackie Bure's paper and Katty Kang's paper are among them, but there are others for multiple disorders. You've heard about STXBP1 and SLC6A1. There's also literature on GABA-A receptors, on LGI1, which can cause focal epilepsy. There's some literature that says that it'll work for SLC6A8. That's a creatine transporter disorder. SYNGAP, which is this group. And there's some emerging data for Dravet as well, SCN1A. It's not clear to me if this is serendipity, if this is somebody working on this gene had a good idea and tried it, or if this is publication bias. If lots of people have tried it and only the people who had success published, we just don't know. The things that seem to be the organizing principle, at least, is they're all epilepsy and seizure conditions. All of these genes in one way or another impact synaptic function. And all other than creatine transporter disorder are heterozygous disorders, which, as you know, means you have one good copy and one bad copy of the gene. So how does it work? The short answer is I don't know, but there's a lot of ideas. So let me show you those ideas. High level, phenylbutyrate does something in the cell, and then there's some beneficial functional impact of that something. And I apologize in advance, the Mac to PC, oh, it worked. Those are my fonts. These are several of the ideas that people have put out there, and I don't know which one of them works. And if you talk to the bench neuroscientists that advocate for these, they feel very strongly, but it's not clear, again, which is the right answer. Regardless, it's probably going to funnel down to one of four or some group of four functional impacts. Either it makes the wild type, your good copy, it makes that better, either by stabilizing it or enhancing its function. Or you've got mutants and it rescues the mutant and it makes an otherwise dysfunctional protein functional again. Or you have toxic mutants that cause problems and phenylbutyrate protects your cell against that toxicity, or something else. And the something else could, we call it compensatory mechanisms. Maybe there's some other thing that is supporting in the cell that provides some compensation, or it could just be a traditional anti-seizure drug that as like the other ones that we have. Regardless, the preclinical data was sufficiently compelling that we thought it was time to give it to children. The FDA has signed off. It's approved. When we started, it was approved down to 2 months, and since it's been approved down to 0. So we launched this study, which was an open-label, multi-dose, single treatment group study. So there's no control group, and multi-dose means that kids take it often 3 times a day, and we've got some kids who have now been on it for more than 3 years. The way the study worked is we do a screening call. Do you qualify? We would enroll you. We would talk every week to get a sense of what your baseline seizure frequency was. And then we would bring you either to Cornell or to Children's Colorado for a 3-day, 2-night EEG admission. And then initially 6 weeks for the first 20, and then we expanded it 12 weeks to make it look more like epilepsy trials. We would bring you back for 2 days and 1 night EEG admission, follow you afterwards and to sort of make sure everything was stable. And then you had the option either to come off the drug or to stay on it. Amgen is promising us the drug through December of 2025, which is why Amber's comments about accessibility and pricing are so important, so that we can transition the goal is to transition these kids onto a commercial product. We published in preprint form our initial outcomes for STXBP1 and SLC6A1. This is a preprint that's out there. The actual paper is under review, and we're hopeful. Safety and tolerability worked out very, very well. We have not seen any new side effects. There are side effects, and the metabolic acidosis can be rough, but the FDA already knew about these, and so we didn't. And that was what we wanted to show, was that we weren't seeing anything new. There's a honey-like odor. Sometimes it's a little bit more like urine, but that's been tolerable and hasn't been a big problem. Some kids get a little sleepy. It can suppress the appetite. The metabolic acidosis can be a big deal. We've had kids in the hospital for it, and it's been quite refractory. It seems like lowering the dose, adding some Bicitra, adding some baking soda helps manage it. Some kids that's been enough, but other kids it's been harder. And then the tolerability has been great. We have most of our enrollees have maintained the goal dose within a few percent, some for years. We've had 5, the numbers are wrong. We've got 46 enrollees now total, and 5 of them have withdrawn either because it was ineffective or because of the side effects. So in STXBP1, I've got results for 4 diseases, and I'll linger on SYNGAP. For STXBP1, we're calling 6 responders to seizures and epilepsy. 2 were not sure for some reason, for different reasons, and then 2 clearly did not respond. One of those, the seizures actually got worse. In SLC6A1, this is where we've seen the most promising results, as Amber mentioned. 7 clear responders, many of whom are still seizure-free. Interestingly, what's happened in that group is that the kids are seizure-free for months, sometimes years, and they grow. And then the mgs per kg, the weight-based dosing drops, the seizures come back. The families get very nervous and almost frantic, but for all of the 7 responders, when that's happened, we've increased 6 of them, not all 7. We've increased the dose, and the seizures have gone away. The reason that I said 6 is not because they didn't respond, but because it's someone at the other center. I don't know them as well. And then there were 3 that were sort of indeterminate, not because they didn't respond, but for other complications or other subtleties. 1 did not have seizures when we started, though developed them later. 1 has not been able to tolerate the full dose, and so is only at about a third of the dose. And then 1 had acidosis, went to the hospital, withdrew. The seizures came back a year later, and we re-enrolled. So we don't know, did it work? Did it not work? We don't know. Here's the SYNGAP data. This is what you guys are here for. So we've given it to 9, and we have 12-week outcomes for those 9, and we're calling 6 responders. What you'll see, 6 responders, 1 indeterminate, or we're sort of still not sure whether to call it a win or not, and then 2 very clear non-responders where the seizures either had only transient response or no response at all. In those 6 responders, you'll see they all have truncation mutations. All of them had drops, with 1 having eye flutters. The frequency was often very, very high. They're not all seizure-free. Some of them are or have long periods of seizure-freedom, but many of them are still having a few. And so it's not that we stopped the seizures entirely in SYNGAP, but rather that we substantially reduced the burden. The thing that I've been excited about is that for all 6 of those responders, when they were at Cornell, we captured seizures on the EEG. When they came back, for 4 of those 6, we did not. And so that sort of gave us some physiologic comfort that the clinical response in which there was a reduction of seizure was backed up by the EEG data. We've also done GABA-A. We've given it to 5 children with GABA-A receptors, and we think there's 2 responders. I wanted to end briefly for a plea, and actually for SYNGAP, a compliment for the natural history work that you guys are doing, which is amazing, fundamental, and just so important, and also for EEG biomarker. And my apologies, I haven't been in the conference, and so if there was already a talk on EEG biomarkers, whoever gave that talk, kudos to you. Why is this so important? So imagine a developmental space where you've got the chronological age on the x-axis and the age equivalent on the y-axis. And so you do a test, and then you see what age does this test suggest the person is. A neurotypical child will follow along the diagonal, because as they grow, their scores improve. A child with a DEE, what happens with a lot of these DEEs is that they start delayed and the delay gets worse relatively, meaning that they sort of plateau. And so their peers continue to develop, but many of these kids don't keep up. If there's a treatment that works on development, you'll see a trajectory something like this, that they'll get better, but they may not quite get to normal. And so doing these calculations to figure out, and often requires fairly large sample sizes, and to even know how many to enroll, you need that natural history data in order to make sense of that. For example, these are the developmental trajectories in SLC 6A1. This is Vineland, which is a commonly used measure, and these are 4 domains: receptive, expressive language, and gross and fine motor. What you'll see is that all of these kids are below the diagonal. They're all developmentally delayed. And the trajectories are sort of a mixed bag. Some kids get better. Some kids get better, and the slope of the line is better than the diagonal, meaning they're catching up. And there's some kids that are flat. What I don't know is if this better than they would have done without the drug. And so in SLC 6A1, there's enthusiasm for natural history data, STX, with what you guys are doing with the END study, with the STAR study, and the SYNGAP natural history study is so foundational. I just wanted to emphasize that. The other thing I wanted to highlight is the importance of an EEG biomarker. So my respondingest responder, again, in all the 46 kids, this is the kid who has done the best. This is this 5-year-old boy's EEG when we started. For EEGers, you see the sort of generalized spike wave there. But this is one of his seizures. His eyes would roll back, his eyes would flutter, and he would lose focus. This is compressed EEG, compressed spectral array analysis. Each of those little spicules in that strip is one of these seizures, and this is 1 hour of data. So this child was having dozens of brief seizures an hour. We started Ravicti. After a few days, mom said that the spells seemed to have gone away, and when he came back 6 weeks later, his EEG was clean. It all went away. And here's the compressed spectral array that's normal. So what's nice about this is if you could quantify this with a number, the EEG went from a 37 to a 3, then that becomes very compelling to regulators, very compelling to journal reviewers, very compelling to insurance companies, whoever it is that you're talking to. If you can quantitate this, the challenge with EEG analysis is that most of it is its visual interpretation, which we know has medium to low inter-rater reliability. Limitations, small sample size, open label study. Sometimes we had kids that had tonic seizures. Those typically happen at night. You never know whether you're counting them all. Absence seizures and staring spells are very difficult to count. And then we don't have that baseline developmental data. Next steps, so for the SYNGAP data, for the GABA-A data, we also have some Dravet data. We're working to collect the 1-year outcomes, and so we'll have all that data a year from now, and then we can get that out and published. We have development, sleep, and quality of life data, but we're interested to see if there's natural history data to compare it with as a collaboration. And then the EEG work is so important, and so the more labs working on this, the better, so that we can have sort of conversations and figure out what's going to be the best way to measure this. From a regulatory standpoint, the U.S. and Europe are both complicated in their own ways. In the US, what our strategy is called the compendium strategy. There are these compendia that list all of the drugs and their indications, both on and off label. And so oncology in particular uses this for drugs when there hasn't been a trial, but it does seem to be working. So our strategy is to work with these compendia to get it listed. We got a rejection for one kid that we wrote Ravicti for, where the insurance company explicitly said, you've written for off-label use. We looked at our compendia and we didn't see this listed, so we're not paying for it. So if we get it listed in the compendia, we'll have better luck. A reduction in the price will also be helpful. In Europe, it's very complicated. The repurposing office in the UK is like, unpublished data is fine, just send it along. We've heard from sort of anecdotally from the Dutch that they want the published data, they want it peer-reviewed. In Germany, they've been able to get it for a dozen kids or some in the STXBP1 world. So Europe is very different. But we are keen to get this stuff get the trial done, get it published so that we can get people access. And with that, I will say thank you.